Hi, I'm Ralph Preston, and welcome to our Tuesday Stroke Buddies Stroke Survivor Support Group meeting. That's a mouthful. Today, I'm really excited to have Shauna Young here. Shauna's an OT, and this is something I've wanted to do for a long time, which is kind of talk about basic hand and arm mechanics and what to do with about getting your hand moving and better again. This is, oh gosh, in the recovery area, this is either number one or number two of the questions that people always ask. They seem to be able to get walking easier than they seem to be able to get their hand moving. Not everybody has an occupational therapist in their insurance plan or their situation. Why, in fact, a lot of people don't even have a physical therapist. Anyway, Shauna, love to for you to tell us a little bit about how you became an OT. I read in your bio that you have always wanted to help people, and that intrigued me. And then maybe do a little bit on basic hand and arm mechanics, and we'll get into a discussion.
Okay, that sounds good. Thanks for having me. So I knew since I was really young, I wanted to help people in the rehab field. My mom, as a teenager, had a brain tumor. I didn't know my mom when she was a teenager, but my mom to this day has some residual deficits from her right side being affected from the brain tumor that wrapped around her brainstem primarily. And so she had surgeries over years of her teenagehood. So I always saw my mom struggle with some, mostly fine motor tasks and balance tasks. I always felt the need to try to help her, try to make things easier for her, figure it out, or help her feel comfortable with things. And so I then my aunt is also an occupational therapist. I thought I wanted to go into physical therapy. I started studying that. And then I learned just the differences between PT and OT. And I felt like OT was a really good fit for me because I really like being, I don't know, I guess like a really close and personal with the self-care and really meaningful tasks that somebody needs to accomplish, their roles, and being able to focus on that and just the variety that comes with that as an occupational therapist. Since we look at vision and cognition and perception as well, I loved all those areas too. And so that's what got me interested in OT. And so I, went to school in Georgia, and then my husband and I, when I graduated OT school, we moved out to Denver, Colorado, and I worked in a brain injury hospital, Craig Hospital in Denver. And so they only focus on spinal cord injury, brain injury, and stroke, some stroke, but primarily brain injury. And so that's where I learned. I got a lot of mentorship there, on the job training, a lot of continuing education there. A lot of opportunities for mentorship from people, from the neuro perspective, vision and perception. So I also trained alongside a neurooptometrist there and was one of the vision clinic leaders. And so our therapists would bring our patients to the vision clinic and say, this is what's going on. It's double vision, it's a visual field loss, blurry vision, somebody's not paying attention to things. And the eye doctor would look at them, but I would help make recommendations on what exercises and activities they could do, and then work with the therapist to try to help them implement that as part of their plan of care too. So I have this other love as well. And then I also worked at a teaching hospital, University of Colorado. And so I saw a wide variety of diagnoses there and complexities. And I worked on the acute rehab. So I got to work with people for a long time. And also at the brain injury hospital, I got to work with people for a long time. It was kind of a miracle, magical bubble place where people could stay for months. And unlike, the real world usually. And so, yeah, so I had that pleasure of working inpatient, outpatient, and also community reintegration, helping people get back some of those skills towards a driving evaluation, working with the vocational rehab counselor. So I have a wide variety of experience that way. We had a lot of specialists to actually dive in deeper to those areas. But, I was able to recommend people for a spasticity clinic where they got Botox injections if that was appropriate. We had serial casting for people with a lot of spasticity, if any of you have heard of that, but a cast on, a limb off in my situation, usually the wrist and hand or elbow. And I'll touch on that a little bit later. But anyway, all of those we had sort of clinics for and experts in. And so I got to see how those played out, when someone was appropriate, what it looked like afterwards, how effective it was. And then when we moved here to North Carolina and we have 2 children, I wanted to have my own practice because I found out there wasn't a lot of outpatient OT for people after brain injury or stroke. So here I am. So I started a private practice and it's mostly mobile. So I go to people's homes. And then I'm also reaching forward with some telehealth ideas to help people in our state. And then hopefully eventually outside of North Carolina too. So that's a little bit about me. So I thought, we were going to talk about the hand today, and because the hand bone is connected to the brain bone, it's a complicated topic, right? So all of that happens within the hand is because with a stroke is because it derived from the brain and any damage there. And so we'd be remiss to not talk about a little bit of the neuroplasticity and like the major principles of motor recovery that makes rehab successful. So I want to start with that because I think that's really important. And then we'll try to break down some different areas towards the hand. But they're all connected. So we'll kind of generally speak to some things, and it wouldn't be, we couldn't really talk too in depth on some of these areas. But so basically some of the major areas for motor recovery that are important is repetitive practice. And that's what the literature is showing. We have to practice a lot. And what does a lot mean? They don't for sure know exactly how many repetitions. They can't tell us that, but the animal studies they do are over 400 repetitions in a day of a movement. And so like Ralph, you mentioned earlier, a lot of people are up on their feet and walking. And, if we could walk on our hands, maybe it would make it easier, because we'd be using our hands more. We'd be forced to do that, right? But our brain starts to learn a pattern of compensation pretty early on if we're not using it or we're not successful. And we make a choice at the time, we start compensating, and that can make it challenging for us. So mass practice, and we're going to go into this a little bit as we go, but we have to practice a lot. We have to practice things that are task specific, things that are meaningful, challenging, bring us joy, elicit emotional response. So your emotion drives your attention, and your attention drives learning, and you need to retain what you're doing and learn how your hand and arm can move again. So you need things that, keep you present and interested. So those things are really important. Also, sleep is really important because that's when you have a lot of cortical reorganization. You have aerobic, they show aerobic exercise. However, you're able to safely do that is a good primer for neuroplasticity too. So those are all areas we can look at to see our readiness for an exercise program and how we design it. And a lot of you I'm always impressed to see the exercise programs you're creating for yourself and inspiring each other to do. And so I hope that through some of this presentation, you may learn some ways to think about it that might help guide you forward in terms of like, well, how is it, are we meant to move, and what's going to make it move more, and analyzing your own movements to see where the problem area is or barrier so that you can kind of, use that and guide your own exercises if you have to. Anyway, we said, learned non-use happens pretty quickly. When we're starting to develop some movements, we're really inefficient at first. It takes a lot of our brain power to work on these movements and a lot of energy. And so having grace with yourself, having adequate sleep, and good self-care is really important. So talking a little bit about barriers, to recovery, just things to consider that you may need to address to help you further is your mood. So, if you have depression or, challenges with fatigue or that you can address with your physician or through exercise, that's really important. And then if you have any perceptual problems, so if you have trouble noticing your left side, for example, you're not looking at it, you don't know where it is, you really need to work on that. If you can't feel it, those are all areas that are going to impact your success too. If you have a painful shoulder, subluxation, or you need to address that too, and that's a different topic, a longer winded topic too, in terms of bracing and taping and stimulation and those kind of strategies that can come with that. But that's important to address at the very least through positioning and not letting the arm hang and all of that. And so, excessive spasticity is another one too that people really have challenges with that affects their ability to move. And, spasticity is going to vary on a continuum, in terms of how severe it is. And then contractures, with a shortening of the tissue, that's going to make it more difficult. So just keeping these things in mind that we may need to be addressing these things in a deeper level is really important. I think going into the sensation piece, there's a lot of ways that we can address sensation for if you have lack of sensation or perception. There's kind of like two approaches. You can take more of a passive approach. Sometimes if it's appropriate for you, disclaimer that I don't know if e-stim is appropriate for any of you without an evaluation, but if, electrical stimulation or TENS is appropriate and there's no contraindications for you, that's a nice way to bring stimulation passively if you're not able to actively move the arm and hand. You can use that through a TENS machine. Sabo has a new glove that's really cool. I don't know the price on that, but it's pretty cool, but it's constant stimulation that way. You can use massage, vibration, touch, but you have to be doing it multiple times per day. If that's where you're starting and you don't have movement, you need to be there. Mirror therapy is a good tool I'll refer to throughout here. Throughout this discussion, mental imagery. I know I've seen some discussions about that. It's a hard tool for people to use because they feel like it's so easy to get distracted from imagining a movement, looking at your hand in a mirror, things like that. But you should be spending about the same amount of time doing those exercises as if you were doing physical exercises for that arm or hand. So if you can't move your arm and hand, if we're starting there, then do you guys know what mirror therapy is, or would anybody like me to speak? If you want to put a hand up or something, I could.
You could go into it real quick. There's,
Yeah.
some people refer to bilateral therapy as mirror therapy. I'm calling it bilateral these days. You're talking about mirror box therapy, I assume.
Yes, right. Yeah, so mirror therapy would be like, I have a mirror here. This is not, but I have my affected hand behind the mirror, and I'm using my unaffected side to do movements, calculated exercises, repetitive. I'm doing this for the amount of time I would be doing exercises with that hand if I could, because what we're trying to do is increase the representation in our brain for that limb, for your arm and hand. And so if you're able to, you can do some of the movements and try on the other side. But people use that for pain as well, after amputations. So it's a good tool that way. And but then the mental imagery is just imagining yourself doing it. I think combining it with what you mentioned, Ralph, the bilateral, kind of mirroring what you can do with your other hand to help it is a good way to do that. I think also bilateral training is just using two hands to complete tasks versus doing it one-handed. So in whatever way you can, you are manipulating something. or stabilizing how you can with one hand, whatever way you can make contact for the two hands to work together. So kind of, two different kind of things there. But those areas are really good. And then as you're actively able to move and you need to improve sensation, you can do different activities where you might have like a bucket of different objects among sand or ice or whatever, and you're trying to reach in and try to discern what you're grabbing, what you're feeling. Can you find all the round things? Can you find the coins? Can you find the blocks? Can whatever it is? But you start to train yourself to practice more that discrimination between different objects, different feels, which of these are warm, which of these are cold, and you start trying to build that. And so that, kind of is its own topic. But I think as we're exercising, we should be having a multisensory experience. So I say that as it's its own topic, but really, like, we should be utilizing that as much as we can. So I see a lot of people exercise who are doing really passive approaches, where they could build on that, make it more robust exercise by looking at it, willing the hand to move, using some of these strategies, using touch more, rubbing, using lotions, and actually being more active in the process of it.
Go ahead.
Yeah, no, go ahead.
I was going to say, I got my hand back through mental imagery. I mean, they basically told me to stare at my hand and try and move it, and I thought they were crazy. But I didn't have a plan because I'd had a stroke like 5 days earlier, and I didn't know much about strokes. So, and I've kind of recommended that over the last 13 and a half years to people, and I think they think I'm crazy, just like I thought other people were crazy. But Bob Anderson will tell you it worked for him, and it's worked for a number of other people since then. So and Dr. Hetzler, our neuroscientist, validated it. While I'm on him, he also, when you were talking about like the mirror box therapy, I learned through him that actually 15% of the was it ipsilateral. 15% of the signals from one side of your brain actually go to the other side. So we think the brain is completely bilateral, left controls the right and everything. But if you're, let's see, I'm right side stroke, left side. So when I move my left hand, some of the signals are going to the right. Same way when you move your right hand, some of the signals are going to the left. That's possibly why bilateral therapy works. And I found that to just be astounding, for almost everything. I started trying to learn I discovered it kind of on my own, although it certainly existed before I sat on the edge of my bed and tried to make my hand work again. But I've just found that, and I'm stolen Leslie Hadley, the yoga teachers, uses the teaching side and the healing side. And I love that language. So I use that now. So if you ever want to know what, this is stroke survivors out there. If you ever want to know what your one hand should be doing, just ask the other hand. And you can even try and engage it, because you definitely can do things. I've done my demonstration, where I do them. Well, look how smooth that is. That's not, I should do it right. So that's not very good. Kind of jerky. Look at this. If I do about 5 or 6 of them, you can do patterning too. There's one good one. There's 2 good ones. There's 3 good ones. It's falling apart. Oh, time to repattern. So, I did a lot of stuff like that. And most everybody in this group is pretty familiar with concepts like mass practice. And when you're talking about like involvement and stuff, we call it either involvement, or we use the term therapy is all around you. That means get that hand moving. And almost everything you said had to do with movement. Get the hand moving. I think people spend too much time worrying about walking. And gross motor skills of walking come back. I'm not saying you should ignore it, but you know, it's important, I think, to jump on your hand. Somebody told me I did so well with my hand because I jumped on it immediately. I understand the concept of neuroplasticity, but he implied that there was something else because I was so early to get on it that I made a more complete recovery than if I would have waited. And of course, unfortunately, people sit around going, oh, what happened to the old me? I want the old me back. And they're kind of, we would say in the video business, they're burning daylight. In this case, they're burning neuroplasticity time. So,
I like what you said about, you know, with the mirroring. And another way for a good mirroring exercise is when you have some movement of the arm, like you were just showing, Ralph, is doing activities where you can match the force between the hands. So in other words, like if I were to hold this cup and I have to hold the same amount of force to keep it upright, or a book or whatever, a ball, I have to keep that force so I'm not turning it over. So being able to match that and use that is a good exercise as well, because you have the feedback of the object too, which you can see, and you know, you can use your mirror and all of that, and that's helpful too. So that's kind of another little tool along those same lines. I think that's good, is using something for feedback like that. And then, like you said, I mean, the repetition is the huge piece of it. I think we just don't get enough repetitions in a day, which is why, like, constraint-induced programs, modified constraint-induced programs, the success is good, is because you're really using it all, that you're certainly getting the repetitions in. I mean, you know, in a therapy session, are you getting all of your repetitions in? You know, I mean, you're likely not. I mean, in most situations, you're not. You have to be doing it at home too. So, yeah, so I think that's huge. But then I think I think it's good to go a little bit into the shoulder before we get to the hand. Is that good with you, Ralph? Yeah. Okay. So our shoulder has to be strong enough to have quality movement, to not have pain. I'm not going to go into a lot, but our shoulder blade has to move on the spine. If we have what's called winging, where it's tipping off the back. Yeah, I mean, it's very common, you know, for people, not even with just stroke too, but more significant a lot of times with stroke. You have to start working on the strength there too. And like I said, it's a topic for another time, but that may be an indicator if you're having winging, or if to do stuff, you're lifting your elbow here to try to do things, or you're keeping your shoulder high like this. Those all may be indicators. Well, those all are indicators that you're having some stability issues in your shoulder blade. And we really need that movement there. So it's important to get that addressed, because you may have impingement, especially the pattern. If above 90 degrees, it's really painful. Don't continue that movement. Stop it there and get it addressed. It's really important to do. I already mentioned shoulder subluxation, and you know, that being its own category of shoulder challenges. So some of the early treatments you can do, and you will likely use from you know, little movement to good movement, if you have any spasticity, is weight bearing. I know I've seen a lot of discussion about that, but I might have some additional ways to speak about weight bearing or give ideas for you. When I think about weight bearing, I think first about even the hand just being able to be on move my thing here, on a stable surface, whether this is on the seat of your chair, you know, if my arm were down here, or on a table, being able to push your weight over, forward, and back. This is kind of the first steps of weight bearing. When you're getting up from your chair, think about all the repetitions you can add from getting up from a chair if you're putting your hands on your armrests. I see a lot of people, and this is not about the lower extremities, but a lot of people just lean over. If you could see me leaning totally on my other side, away from my affected side, instead of taking that opportunity to push through. Even if you're taking your other hand placing it there, dropping the wrist, as we'll talk about, to get it off the armrest, trying what you can to push off the seat, push off the armrest. Those are all opportunities that are important, and they're also weight bearing. But so that's one area of weight bearing. There's many times to do that when you're standing at the sink, brushing your teeth. If you can't brush your teeth yet, or you don't have any kind of possible movement yet, you can put your hand there. And I like to tell people to put like a tape or an X that's where your hand goes. If you cannot move your hand in any other way, at least give it a job to stabilize there. Yeah. Were you going to say something, Ralph?
Oh, no, I was just going to say, I was going to ask you about weight bearing, and actually, David Lauderdale the other day posted a picture of him brushing his teeth, and he had his, he said that's Righty's job, to be there,
Yeah.
open it up. It keeps it open too. I don't know.
Yeah.
I don't know if John Loomis is here or not, but one of the things, John is a friend of mine, a stroke survivor, and has one of the admins of Stroke Sweat Squad. And he's got this theory that I liked. I mean, it was kind of in my mind, but he kind of solidified it with some words, which sometimes happen. He said something about the shoulder being the crane that holds up your arm. And if you don't have a strong shoulder, you're not going to get the arm movement. And I'm interested in how much the shoulder is connected to the core, because it seems like there's not much space and difference between the two. How important is core and shoulder and arm movement in your?
It's really important. And that's actually where I was going to take that next is
Sorry.
can you, no, that's perfect. That's great. Because what I was going to show you guys next is that we should be incorporating more of our body. So when we're weight bearing through our hand, we can be doing a number of, it's not a good video, sorry. Once you place your hand there, you can then create other movements. So getting your hand out to the side, turning your body, bringing your shoulder back, tightening your core here. We're all connected here from our pelvis. A lot of the problems with our shoulder happens because we're dumping, imagine your pelvis as a bowl. And when you're dumping your bowl backwards and letting all the liquid out of your bowl back here, your shoulders slump. If I try to raise my arm here, literally that's as high as I can go if I'm slumped. And when I activate my core, my shoulders, my back, I can go much higher, and that's not an exaggeration. That's a true, if you try that yourself, you see that that's, not possible. So we really have to look at our hips, how they're angled. Are you keeping your bowl, full and level? Because then you can activate more from your shoulder for your reaching activities and whatnot. So I think that's awesome you said that, because I think that's really missed a lot of times.
And I figured I somehow knew there was a connection, but I wanted to hear it explained, and it actually sounds like it's even more important than I thought it was. When people ask, there's this question that goes around that says basically, what would you tell yourself at a month after your stroke that you know now that you didn't know then? And I always answer that core, core, core. It's like Dustin Hoffman and Mrs. Robinson, plastic, plastic, plastic. Because core is really important. I never heard anybody much mention about it. So I'm glad to get that in. One thing I found that in working with local stroke survivors, that there's like right at 90 degrees, like you mentioned, it gets really a lot harder there and often more pain. That was a stopping place for me. Somebody told me to get a dowel, and I actually pushed my hand up passively with a dowel. And it's important, like you said, not to move into any kind of pain. But I found rather than stopping, what I would do would be to work below that. And I just kept at it every single day. I did it a couple of times a day for 10 or 15 minutes at a time. I'm a kind of a maniac, so I got my hand back and everything back partially because I just went at it like 8 to 10 hours a day. I didn't know anything about mass practice, but
Hmm.
I fell into it
Hmm.
because of that.
And
And
yeah, I was
so
going to say, I think that's important. Yeah, that you worked within that. And a lot of times people find when they can't go higher, they may have impingement of the tendons that enter the shoulder. There may be inflammation there that they need to work, or their serratus anterior in the back is weak. Their external rotators are weak. So a lot of times setting your shoulder blades, so to speak, like making sure it's not tipping out away from the back. Your shoulder blade should be gliding, the tip of the shoulder blade should be gliding towards the armpit. As you move like this, I don't know if that makes sense, kind of how I'm showing you, but it should be rotating and tipping towards the armpit. And if you're not feeling that and it's kind of stuck, you might need some manual work there. But as you raise your arm, you'll feel your shoulder blade doesn't start to move a lot. If you can feel back there, it doesn't start to move a lot until you start to raise above that, and then it starts to tip.
bingo.
Yeah. Yeah. So for those of you that are having a hard time getting the shoulder moving, or you don't have quite enough strength, other than working those key muscle areas, and maybe if you need manual work to get it mobilized more, another way is just to think about gravity. Some people don't quite have the strength to continue the movement higher than that, and that's a muscle grade. You can move against or gravity eliminated, and then you start to work a little against gravity, against full gravity, against resistance, and that's how resistive training works. So if you can think about it, if you can't quite do that, and maybe it's not because of pain, maybe it's because of pain, you can just try laying on your side, putting something out in front of you, like if I'm laying on my side here, and can you glide your arm, imagine I'm laying on my side and you're gliding your arm in this plane, you're laying on your unaffected side. And maybe you could prop a book, some kind of an ironing board, or something, a box, cardboard box, and try to get it level. So raise it high enough that your arm is not sinking down to do the movement, but try to get it level with your shoulder and see if you can get more movement that way, and feel your shoulder blade gliding. As you can do that, you can add a little bit of light resistance if it's appropriate. It's not painful. You're able to do it a lot easier. That may be an indicator that you could use some mild resistance tied at the end of your bed or something. Glide it gently up this way. Same for laying on your back, getting your arm like in a snow angel, eventually adding resistance. And then you work against gravity and doing the same thing. But your external rotators are important too.
Right.
If you're not having pain, but getting strength here, you should feel your shoulder blade glide in towards the spine. And that is often a weak one for people too, with hemiparesis. So that's where I would start weight bearing, moving your arm around. You can also just place and hold your arm, your hand on the wall. Glide up. If you can't quite do that, you've done the gravity eliminated. You can tip an ironing board on an angle, lift up one end of it on something, glide it up and down. You could take the cover off it to make it slipperier, and then working on that, then work on pushing something up it. That's not going to hurt you, but yeah, just pushing it up, until you can do it on a vertical surface, and you're getting more strength there. And then you work towards resistance. And so those are kind of some ways that I think about for the shoulder and the importance of it and strength and all.
What you want to do also is try and this is a whole nother discussion, but um, I found that it was really helpful to do basic blocking so that you were making sure that you were moving the correct muscles. So things with the wall and the ironing board do that, and so does doing it in bed, because you only can do it in the one plane. Again, my friend John Loomis with the side to side, he took a gait belt and strapped his elbow to his side with a gait belt,
Yeah.
so he couldn't move his. So what I'm mentioning that not for a specific thing, although it is a specific solution, we always try and get people to like think about how do you break it down? How do you isolate it? How do you make it easier? How do you get to where you can do some portion of the movement so
Mhm.
that you can work towards the total movement? It was funny because I understand and embrace this concept now. In the early days, I was very much a guy, and I thought you have to do everything perfect or you're cheating. But that's
Mhm.
not the case. You have to break things down and start somewhere. I'm staring at Bob Anderson, who started on the bed with his hand just balling up a dish rag, and then he started moving it across the counter. What we're trying to teach people in these groups is that you're not always going to have a PT. Your PT is, you only see them once or twice a week. Write down questions and get all your questions answered. But one of the things that really is helpful in stroke recovery is being able to kind of figure out things for yourself a little bit. Don't look at everything as and any problem you run into, it isn't an obstacle. It's an
Mhm.
opportunity to create a solution. So
Mhm.
try and think about things and figure them out and make them work for you. I thought the gait
Mhm.
belt, strapping his elbow to his body with a gait belt, that's brilliant.
Yeah, I like that. Yeah. I've also used just like squeezing something between the elbow. Just if you can control it but you forget, you have that extra,
Ah,
and so you can put a little towel roll here as you're
right.
trying to do that too. Yeah. And I think like you say, a lot of times people get discouraged and they hit what they think is that plateau because they are not accomplishing big goals. And sometimes it's important to break it down into smaller goals. So, as we're talking about from the shoulder to the hand, there's a lot of moving parts to reach for a cup, pick it up, or to, get your fork, to eat a bite of food. And so, if you can take a task for the week as an idea or a couple tasks and you say, well, what, and you start to learn and analyze yourself, well, what's required to do that? I have to reach forward. Can I do that? Can I reach forward successfully? Can I reach forward at different heights? Can I reach forward down low, up high, to the side? Can I reach standing, sitting? Can I bend my elbow? Can I reach forward and bend my elbow? And just thinking about that and like how you can work towards those goals, I think, and stay encouraged, because all those are parts that are critical for the end movement. And so it is good to consider that and break down and analyze it for what it is, and for the plateau purpose, but for goal setting. But also there's a balance of it. I think, I think it's important just to be able to move the hand anyway. Like if you have a problem with your shoulder, it's like, well, Ralph, in that situation, you didn't stop because you had some trouble up here. You worked within that. You gave your hand a job. You still did what you needed to do, and you worked within that. And that's so important, because the longer you aren't giving input to the brain that it has a job, it needs to connect with the hand and arm, it makes it more difficult. And they say like the first 6 months are like the most spontaneous and consistent recovery that we see after a stroke. But back to my mom that I spoke about in the beginning, who had a brain tumor, my mom just about 5 years ago learned to she was very motivated to write and eat with her right hand again, after she had not done that since she was 17,
Mm.
13. And so, she's 60, and she learned to do that after so many years. It's not that she didn't have, I mean, to be fair, she had movement there, but it became more skilled and proficient than the hand she had been using for all these years. And so it's possible to change. Like she has more legibility in her hand. I mean, it's just, results may vary, but it just depends, and everybody's unique in what they're working on. But and so yeah, so we talked about the elbow a little bit. You got to be able to work on isolating in and out of that. Can you do that against gravity? And if you can't, then going back to those movement positions that are easier for you, working towards resistance and all of that. Um, all of that's important. And the elbow a lot of times sees spasticity along with the wrist and hand. research for splinting is not great. It's like good for some parts of the problem with regards to motor function and spasticity. It does help to increase the range of motion, or preserve some range of motion, but it doesn't necessarily reduce the spasticity. But serial casting does for those people who have significant spasticity. Keeping that a cast on in a certain position, length, and pull is a good use, and they do that in a progressive way, but a topic for another time, and I'm not an expert on that either. But so then I think the hand, because it represents such a large part of our brain, there are so many skilled movements we have that we can do with our wrist and hand. A lot of times people get really stuck that their hand is closed, and they can wrap their hand around something, but then they can't get it off, and they don't know what to do. Should we just work on that squeezing, or what do we do? Ralph, did you have much in the way of that problem at all, like with the spasticity, difficulty extending?
Yeah, I think everybody does. It's my understanding that the flexor muscles are 9 times stronger than the extensor muscles, so that I mean, our hands are made to hold things. So the opening back up is a part of getting ready to grab something else. Yeah, I definitely had that problem, and early on, this is something I wanted to talk to you about. I call it the great um, flexor extensor / putty debate, because um, when I've talked to people about squeezing, I recommend. I mean, putty's great for a lot of things. I mean, I use it more for. Well, they told me to be careful about squeezing, because if you squeeze too much, you're building up the flexors, and if you have to, well, even if you aren't doing anything, one of the problems that people have, here I go telling an OT um, um, things, but one of the problems is if you have excess spasticity, you the extensors will not overcome the flexors. That's a big problem for people. So it seems they have to get um, rid of that spasticity. That's one reason I think opening the hand with your other hand and getting any kind of movement you can going um, is a good idea.
Mhm.
I it took me over a year to get make a gun with my finger and then do full extension with the gun. That's about all you can do. Um,
Mhm.
I had my hand back. I was rolling my fingers by 6 months. The reason I did that, I want to reinforce something that you said, and that's basically if you can't get the shoulder moving, it doesn't mean, people hear this, there's a progression between the shoulder, the elbow, the wrist, the hand that moves down from gross to finer. That's often true, often the case, but in my case, it went the exact opposite way. My hand and wrist got better before my elbow. It took me a while to straighten my elbow out, and took me the longest to get my shoulder moving. And how did that happen? It happened because, like you said, well, if you can't get your shoulder moving, move down below that area. I was doing 2-3 hours a day of strictly hand. I did every hour on the hour. I'd either walk or do shoulder or do hand. I had broken my shoulder, and one of the things I just lucked into this. I had a bike accident. A lady pulled out in front of me on my triathlon bike, and I was going 26 miles an hour, and I T-boned her, broke my hand and shoulder, and I've been going to the YMCA at 5 o'clock in the morning, so I gave myself a break and got up at 6, and I'd do like an hour of circles and abduction. And every time I abducted, when it started hurting, I would stop, and I just moved. I learned to move things below the pain zones, and I really like. I don't know how you feel about them, but drawing circles with your index finger at your side. I really like, because it seems like circular motions involve lots of different muscles and muscle groups. In order to make a nice smooth circle, you got to have a lot of balance. And what a lot of people don't realize is, like, if you do a basic curl, you've got your tricep working against it falling and your bicep working to, pull it up. There's a balance in our
Mhm.
bodies between one muscle is generally, I'm not trained, but generally you have one muscle that's relaxing, letting go, while the other one is pulling and doing the work. So I found that those circles are, and and guess what? You can't get hurt doing them either. So I like to recommend things, because like you can't prescribe to 30 people in the audience today. I don't know what stage people are at, so I like things that work for pretty much everybody, and you can't get hurt because I don't get to examine people before I make recommendations.
Mhm. Right.
Maybe I get to see a video. So
Yeah. And I think like piggybacking on what you said, if you can't move your hand, but you can move your shoulder, well, then how can you strap something to your hand to make to make it easier to grasp onto something, to give your hand a purpose? And so in your situation, you were using your hand a lot, and that told your brain this hand has a job to do. It's you created that cortical reorganization, that mapping that's needed, and that helped drive some of these other movements because your arm drove that. And then, like you said, with some other people, they may not have the hand yet, but they have some other movement. So they have these things, universal cuffs. You could straps around your hand and helps hold something in place, so you can try to wash your hand or put your hand in a sponge, with a handle, but if you can't hold it and you can't manipulate it, at least help your hand, be of use in some way if you have some movement at the shoulder there. So yeah, the universal cuffs, or there's like built up pencils, the foam, if you need something that if it takes that you're eating like this, and that's what all you can, or like this, that's a little more reasonable. If you're eating like this here, and that's not, with the correct prehension like that you would have. But if you're able to do that before you can quite get there, then do it. I mean, just try your best in order to, if it's a built up handle you need, if you have to do it where it's a little bit more awkward, just do it and work towards that goal of refining the movement and the skill, because that's really more important. Making it more automatic to use the hand, and that helps drive the brain changes. And helps you be successful, and you just work towards that goal. So I think that that's important. And then, one thing too, a lot of times people are dealing with a little spasticity in their hand that makes it difficult. Cold is often helpful for people to prepare yourself for the exercise or the movement. Is cold on the spastic muscles. So in here, if your hand is having a hard time doing that, for like 15 minutes beforehand, with an appropriate barrier around it to make sure you don't freeze your skin too hard. But yeah, so just that is good for reducing the spasticity. It doesn't last a long time, but it helps you to hopefully prepare your hand for a little better movement, maybe a little less spasticity, to have more quality movement and relaxation of those flexors that are so tight. But I agree. It's a balance of the flexor extensors. I don't ever have anybody doing hard, resistive flexing and gripping, squeezing. I think the way I look at it is that these are not strong muscles because they're spastic. They're just not inhibited like they used to be. So they don't have that inhibition to stop the flexion when they're not needed. And so they're still not quality muscles. But if your hand is closed, or you're wanting to practice grasping, do it actively at first without the squeezing hard resistive part, where you can't also try to come out of that position. And that's kind of like how I evaluate it, and look at the movement. I've seen it mentioned here before too, but dropping the wrist down to let go of something is a key, but also getting the thumb out. So let me do this again. Dropping the wrist down can help open the fingers. So pushing the wrist down this way, and then getting the thumb out gently, not ever pulling from the ends of your fingers where you're hyperextending, but trying to grab closer, from your hand. But getting the thumb out is often key in getting it open again. So if you're practicing grasping for things and you need to, then think about that. Try to get the thumb out and then drop the wrist too. Okay, and then we mentioned cold. I mentioned like ace wrapping things to your hands in order to use them. What else? Thinking about your hand as having two parts. You have a power side of your hand that is the squeezer part. So as you're progressing your hand and what it can do, these are the parts of your fingers that can perform all kinds of movements. To hold a key, is one method of how we hold things. Picking up something with two fingers is a different way. So analyze what you're doing and how you hold a variety of things. Like you guys say, therapy is all around you, and I love that. I think that's really important to remember. So you can be creative with anything you have. You just have to get the practice, repetitions in, and the novelty of it. So practicing all the movements that the finger does is really important. What else was I going to say? But yeah, I mean, it can go on and on and on, like using tweezers, to pick up things, flipping cards, drinking out of a glass. Yes. Drinking out of a glass, flipping cards over, flipping a magazine, the movement here and that grip that you do here. This is its own unique. So flipping pages here is even different than reaching over and flip, so the pronation, supination of your forearm here is an important skill. So whether that's cards, and then also along that line, having a cognitive demand. So like sorting cards by suit, or putting out matching cards on top of other cards. You're adding a cognitive demand and sort of that dual tasking you may have heard of as your hand is progressing. So adding that demand and that challenge when it's appropriate for you is good. I've seen mentioned like kinesio tape is a good way for mild spasticity. It's not going to be a significant help for somebody with severe, but it has a stretch on it. And I saw somebody recently post that, and you can use that for the extensors to get the hand open in between. I wanted to stay with electrical stimulation. Electrical stimulation versus TENS, is what's going to get more of a robust muscle contraction. A lot of times people use TENS too, and if you turn it high enough, you can get some as well. But I've always used electrical stimulation for that purpose, for getting a good muscle contraction. But practicing, if you're using that and it's appropriate for you health-wise, you should be practicing being really active when you can. So turning it on and letting it go, you're getting the repetitions in, and it still is driving a connection with your brain, between the hand and the brain. But if you can do an activity within that, so when it's if you put it on the extensors and it's on, then when it's off, you grab and you place it where you can. You start where it's comfortable. Slide it along the table if that's what your shoulder can do. Slide it down to the floor to let your elbow drop and for you to let go easier. Reaching higher might be harder for you, and so but timing it with your when it's on and off, that cycle that it can do. They even have trigger ones too, where you can press when you want it to go on and off. I know Sabo does, but I don't know who all does. But you can time it for when you want it to occur. But you should be really active in the process of using eSTEM, not just passive. So you might do that it varies for what's appropriate for you, like 10 to 30 minutes, few times a day if it's appropriate for you. But you have to, put your brain power into it and give a task to it. And then when it's off, try to continue some of those movements and see if you can continue that pattern that you just created and had success with. And so that's one thing I think about that I see a lot, is just making that more active too. If you're, really stuck and you're feeling like I have this movement and I can't go further, there is really good research around modified constraint-induced therapy, but it's really, they found is super difficult for people to actually carry out from the time perspective. But even just a half hour to 3 hours a day, some that continuum for an appropriate person with the right amount of movement. So that means like about 10 degrees of wrist, even like 10 degrees of a finger, a couple fingers, getting the thumb moving a little bit. You don't have to do a constraint induced program, but I like some of the principles at least to use from it, which is that repetition. You're forcing your hand to do what it can do, but you have to be grading it and, as appropriate to make things a little more challenging for yourself, to have success with it. And just really, that's what it's about, is the repetitions. I mean, that's what it comes down to with that. I mean, there's a lot of contraindications for people who shouldn't use it from a balance standpoint, safety standpoint. There are things you shouldn't use it during driving. And so there's a lot of checks, or lots of boxes on that checklist to make sure it's appropriate for you. But that's another way to really push it if you have the time. And caregiver support, I feel like, is important. The mental health, the drive, motivation, and some prerequisite skills. It's just kind of another way to kind of move forward with that. But I think like the main things are just, how can you make your goals, make your goals automatic, or like for things that can be automatic successes for you. Like, so making those goals a little bit more smaller subtasks, and then combine those as you grow with that goal. So you can put it together as you have multiple trials of success. And then I also recommend sometimes people to use a reminder watch. They have vibrator reminder watches or smart watches, and just as a way to remind yourself to use it more. If you're not going to go like a full, modified constraint induced program, you just need more repetitions and ways to know to use it. Assign your hand those jobs to do. Think about how your hand is meant to move by looking at your other hand and the prehension that it has, for opposition, manipulation. Like we talked about, the skilled and the power side, like being able to grip. So as you're picking up, you're holding, and this part of your hand has a job to do here, or maybe it's holding something over here while you try to do something with your fingers. And that's one way to kind of progress some of those hand movements and manipulation, is making it multitask, making your hand multitask a little bit.
Making it more complicated.
Yeah. And I think for the plateau, a lot of times people, feel like they've plateaued. And I think, as I told you, like my mom made changes 30 years later. They say like people, the quickest changes are in that first 6 months, but people can change over years and make progress. So it's all, what will help you to do that. It's the goal setting, sometimes journaling for people. What could you do today you didn't do yesterday? I mean, that's huge for perspective, because when you're living in it every day, I can only imagine that it's hard to sometimes notice those subtle changes. You might notice whether or not you zipped your pants that day, but maybe you didn't notice that you can pinch now, like a smaller movement that's towards that bigger goal. So, and then just like we said, addressing mood, motivation, getting accountability partners, like your group. You guys, are always encouraging each other through video and helping encourage that way and asking questions. And I think that that's huge too. So it's just, change your goals a little bit. If you feel like you're hitting a plateau, maybe you need a new therapist, you need some buddies to check in on you, you need a new focus, something more fun to do, to make it more interesting.
One of the things that I think I've learned about plateauing is that the brain wants to be challenged. So a lot of times people hit plateaus when they keep doing the same thing over and over again. So mixing it up is good. Two things I want to clarify. One is I know what constraint therapy is. Basically, the idea that Shauna was talking about using that hand, some people like basically put an oven mitt over their non-affected side. Dr. Taub, I think, tied people's hands behind their back for some period of time, probably 4 hours, because he also believed in mass practice. But anyway, People do it for like half an hour with an oven mitt. I never did that. I just kind of naturally fell into it. Well, they preached involvement at the rehab hospital, and I said, no, I want to come up with another I word, like involvement, that's beyond involvement. So I came up with integration, and that was the concept of just using it everything. We don't know how we used to open a pickle jar. So now I open them everything with my left hand. I'm pretty sure I did it with my right hand
Mhm.
pre-stroke. But and then in the early days, I would take a glass and I would pick it up with my affected hand, and I'd put it in my unaffected hand to open the refrigerator with my affected hand. Then I'd put it back and put the thing in. I was going through conniptions in order to maximize what I was doing with this affected hand. The other thing was I used these water glasses or my tea glasses. Whenever I did, here's a real simple technique that I found that you can use during the day. Whenever you don't like something, do it 5 times. I had trouble like letting go or picking things up. So if I didn't like the way I put down my water glass or tea glass, I'd pick it up again and put it down 5 times or 10
Mhm.
times until I was happy with it. I tried often to end with a good one because I had this crazy feeling if I ended with a good one, maybe I was patterning my brain somehow. I don't know. I did most of my recovery in a vacuum, but I also, tried to think about it a lot, and I really lucked out. I lucked into bilateral therapy and mass practice and a bunch of stuff by being a maniac, kind of like Bob Anderson there, who was recently eating pumpkin pie with his affected hand. Um, yeah, he's doing some now. I know, Shauna, you probably got a schedule. I don't know if you got time, if anybody's got a couple of quick questions or not. Do you
Yeah,
have?
I'd love to.
Oh,
Yeah, I got about 5 minutes.
okay. So I'm sure Bob Anderson's got one if nobody else does. I can always count on Bob. You might have to unmute yourself there, Bob.
Hi,
Yeah.
Shauna. Wanted to find out, or maybe Ralph could post this for us. Do you happen to have a website or Facebook page, some social media,
Mhm.
channels that we can go ahead and take a look at and connect?
Yes, the timing is terrible because I just created one.
Oh, okay.
But you could be among the first subscribers. Yeah, I just have one video right now, a community project that we've started that's not stroke related, but that is my goal and intention to create one. So I made the first step, which is to breathe it into existence, type it into existence. So I do have one, and that'd be great if you are able to share that. And I do plan to add videos to that over the next few months to really
Okay.
try to, yeah. So that'd be
And
great.
will you go ahead and share your email with Ralph
I,
then, so he could
I,
post it and we
yeah,
get contacts?
Bob, I typically under the description when I post this video, under the
Okay,
description, I will put like, well, I typically put the links to like Shauna's website. I don't know her YouTube channel yet, but I'll get that and her email and like a link
great.
to her bio and stuff like that. How you can get in touch with her right away. And then sometimes I put like her bio below that, but I always put the contact information um, up front. And um, I have, you know, I have no problem with the whole, money, no money thing. I'm a survivor. I do stuff on a volunteer basis. Shauna has to make a living. She offers telehealth stuff. I'm hoping that, um, that this this recording, this session this morning, can help drive some people her way, because I think she can help people. She knows what she's doing. So, and also, I'll go on record. I told her on Saturday, she doesn't live that far from me. I told her I'd drive up there and shoot 20 videos with her in one day. If she wants to shoot 40 of them in 2 days, it's really a matter of up to her what she's going to do with her children and her career and everything during that time. But I'm a big believer in that we're all supposed to be wearing the same uniform and playing for the same team, and I would do anything that I could to help her with her YouTube channel and drive business her way. And frankly, try and see if we can get her to come back. I think that any kind of relationship has to work for both parties, or it doesn't work at all. It'll fall apart. So that's how I operate, and I'll put everything about Shauna in the post, and when I post it in the groups too, I'll typically, put all the contact information. Because there's
Thank
no
you.
way you can touch on this. I mean, I thought we did really well for an hour, but I mean, this is a 100-hour discussion.
Yes, it is.
You could do, you could do 6 hours on the shoulder. You could do 4 hours on the elbow. You could do 4 hours on the wrist. You could do 20 hours on fine motor skills.
Yeah, absolutely.
And
I was just telling a friend last night, I said that I was going to do this. We were going to talk about the hand. And she said, well, how much time do you have? And I said, that's going to be about an hour. And she said, wow, that's a lot to do an hour. I was like, but we're also going to touch in on the shoulder. And so anyway, yeah. So the videos I plan to do will break down, get in more depth in a lot of the areas we talked about. So if you felt like it was useful, then please do, go to that channel and just be patient with me. But I do have short-term goals, quick short-term goals towards that.
Good.
And now I'm, have a nice organization here of all the topics we talked about that were useful to people. And so hopefully that can come to fruition pretty soon.
Well, Ralph,
remember, I went on public record saying that I will help you. I'm dead serious.
Thank you. Thanks. We'll chat about it. I
well,
thank you for
I
having
hope
me.
Shauna comes back for part 2, working the legs and the foot.
Oh, I'm not your girl for that.
Oh, okay. Well,
but
I will say,
the shoulder.
I will say this though, that the hand is really important to look at during mobility, because there's a lot of patterns of gait and that happen where that increase that synergistic pattern. If any of you get that, where your hand, and your arm want to draw in, but there's a lot to look at with gait that affects the hand and the arm, and ways to move out of that, and how you weight bear over your legs. So I think that's a really important topic. I mean, I'm not a physical therapist, but I observed that through, I worked with some really great PTs, and I get to see often the difference in how somebody takes a look at that and what's appropriate for somebody with hemiparesis or spasticity in their lower extremity, and what this person's gait looks like versus this person, and how that affects their hand and their spasticity following walking. So I think that's a great topic for someone, but it's not technically in my lengthy part of my education, and so not my scope of practice as much as a PT.
Well, maybe we can get a PT and an OT to discuss it.
Yeah, that'd be great.
Who would have thought? I mean, I learned a lot today. I mean, I'm the one who brought up the core connection. I knew there was one, but I never thought anything about like hip position, your concept of the bowl of water, keeping things flat. That's what you're trying to do when you build up like your transverse abdominal muscles and everything.
Yes.
You're trying to keep that that hip in a nice, no dip, no rotation kind of position. So
right.
It's like a lot of things. We can only do an hour at a time, but if we keep, how do you eat an elephant? One bite at a time. So we're not going. I'm not going out of the Tuesday meeting business. Well, I guess I am for about 3 or 4 weeks around the holidays, because it just doesn't seem to make any sense. But we'll be back next year, and well, I've actually got 5 this week: today, tomorrow, Friday, Sunday, and next Tuesday. So there's plenty of topics to discuss, and we'll just keep at it, and would love to have you back. And for the 3rd time, I'm dead serious. I'll come up to Hendersonville. I know right where it is. I lived in Franklin for 10 years, so
yeah, we'll have to chat about it.
Yeah, we will. So
yeah,
anything I can do to help you, I will. And
thank you. I appreciate it.
I appreciate you taking your time out of your busy schedule.
Yeah.
and spending a little time with us today. I think it was really valuable. And one last thing would be, last week we did jump on it. Neuroplasticity lasts forever, as you heard from Shauna talking about her mother 40 years later or 45 years later. I've proven it too with things that I learned 11 years later and videotaped. But there's that 6-month window, and it doesn't go away at 6 months. They have to pick an arbitrary figure, so that's the figure they took. Last week, Bob and I and Veronica Coney talked about the importance of jumping on it. So, get that movement going early on in the hand. That was just apparently key for me, was to, not say, okay, well, I can't move my shoulder, so I'm not going to do anything with my arm. With my hand, your hand will work fine. Take it from me, because I did lots of hand exercises when I could barely get my shoulder up to here. And yeah, when I do this, people tend to think, oh, well, he didn't really have a screwed up hand. Well, I'll tell you that when I got sent home, I couldn't lift my thumb off my lap.
Mhm.
I couldn't rotate. I started by trying to lift my thumb and rotate my hand because I couldn't pick it up straight up. And I got a little bit of rotation, a little bit of thumb movement, and then it started to come.
Mhm.
So jump on it.
Jump on it.
That's right. Thank you so much, Shauna.
Thank you. All right.
All right.
Sure. Okay. Bye-bye.